All right, Jan, we're burned out. Now we're not burned out. We've learned how not to be burned out.
That's right.
Now we're going to deliver a baby.
Yeah, fantastic.
Which is actually usually a very exciting and fun thing in the ER, but every once in a while it can go bad. So
it can be terrifying.
It can be terrifying.
Yes.
It can be terrifying. So the reality is this whole article is meant to be emergency delivery. This is what happens in the ER. And the reality is just when you have a baby, about 1 in 10 kids will need something done after delivery. And about 1%, so 1 in 100, will need true resuscitation. I need to bag you, I need to intubate you, I need to give you something, I do CPR. So, and the reality is, interestingly, in the ED, it's about the same. It's about the same number, 1 in 10. So meaning 9 in 10 babies you deliver in the ER is fine. Yeah. You're not gonna need to do anything, but 1 in 10 may need you to actually focus on a little bit more, not necessarily CPR, but a little bit more that you need to do. So this article focuses on that, the unexpected delivery in the emergency department. That's the whole point of this. And it integrates the guideline that came out in 2015 that updated the neonatal resuscitation. And there was a lot of huge change in that, but there were a couple of things that were different. So I mean, you know this, it's like there's the honking in the ambulance bay, which either means for us it's a homeboy drop-off, that you actually have a gang member that's like thrown out the car, or there's somebody in labor in the car. And I've been to a few of those actually in the parking lot. If that's happening, there are a couple things you need to kind of like be zen for a moment and say, okay, what do I need to ask about this pregnancy to be able to prepare for this particular delivery? What do I need to resuscitate this baby if this baby has any issues? And then if I need to, what are the principles and steps of resuscitating a newborn? So it's basically you zen out and you go into sort of these are the basic
Reach
things I
into
need
your
to know.
hippocampus
Yes,
and
you do.
find
And
these
pull
memories
these
from your
memories out of there. Because, and again, while you're pulling them out and you're palpitating and having all kinds of anxiety, realize that 9 out of 10 babies aren't going to need you. Okay, you're going to be able to say, "Yay, mom! It's a boy or it's a girl," and yahoo, and you're done. But 10% will. So with that idea, the things that you're going to want to know about this pregnancy are: did they have prenatal care? Did the patient know that they were pregnant? I've had one of those in the ER, didn't know, and had a baby in the ER. She didn't know she was pregnant. How many babies are in there? Every once in a while, I had this in the parking lot.
Yeah.
I had delivered a baby in the parking lot, and the dad was really concerned after baby came out because there was another one in there. So that was interesting. Is basically, what's the approximate sort of gestational age? How far along are they? And you can kind of test this a little bit by poking on the belly. If they're over the umbilicus, at least it's a potentially viable kid.
Yep.
Any complications of the pregnancy, particularly gestational diabetes, that'll tell you that the baby may be big. In particular, and that one's particularly scary. Or rupture of membranes, so they have been leaking for a day. You're going to worry about infection, et cetera. And do they know of any fetal abnormalities? Have they had an ultrasound where they know the kid has some sort of problem that will make the delivery more complicated, or resuscitation more complicated? And once you know all of that, you can assemble your team. And honestly, if you have an emergency department with an L&D, just call the L&D suite and say, bring down the warmer, bring down all the resuscitate, get your BOA kit so you can deliver the baby, have everything ready, because that's half of it. And let people know, got a baby coming in, here's what I know about it, I anticipate this might happen. So everybody knows what to do, and kind of point around, delegate tasks to who's going to do what, which is like every resuscitation.
Exactly.
That's a great use of sort of your resources. Yep. So assign team members, and we're not talking about the mom in this particular sort of review. We're actually going to focus strictly on that baby. So someone's over there taking care of mom while you are there taking care of the baby. So when you have the equipment that you need to have a warmer. It's super important to have a warmer. Really, really important. So if you have one of those up in L&D, have them bring it down. So we have one in our ER, but not all ERs do. Yeah. So make sure you have that brought down. Airway equipment, make sure you have the teeny tiny stuff. So this isn't just the stuff that you're used to intubating even 2-year-olds. This is the teeny tiny stuff. So make sure it's the little kid stuff. Yeah. And vascular access equipment, which includes things like doing a catheterization of the umbilical vein. Umbilical line. So having the ability to put something in there. So this is basically, they integrate, I mentioned earlier, the neonatal resuscitation guidelines from 2015 into this. And basically, the important questions to start out with: gestation, yes or no? Once the baby's born. Okay, baby's out, woohoo. Now, is the baby a term gestation? Okay, and you can look for things like creases in the hand. There are a couple of things you can look for on exam. But is this baby term? Is the baby has good tone, that little tight little thing that's been in there all wrapped up? And is the baby breathing or crying? And if the answer is yes to all those, term, good tone, breathing or crying, mom gets it. Keep the baby warm, but mom gets to hang on to that baby. And you can do skin to skin. It's wonderful that mom gets to hang on to the baby. But if any one of those three it's not term, the tone is terrible, the baby's not breathing or acting normal, you take the baby away from mom and goes right to the warmer, and you start to do your assessment of the baby.
And that is your new resuscitation bay.
Exactly.
Yes.
And that's only, again, 1 in 10.
Yeah.
So it's 9 in 10. Mom's going to be cuddling and everyone's going to be crying, and it's going to be a great day.
Yeah.
So to assess that baby, now you have the baby on the warmer. First thing you're going to do is dry that baby. And always, if you go up to L&D, it looks so brutal. And they take this little creature and they're
aggressive.
rubbing all over and they're flicking there and they're rubbing the baby's back. But that's important. So these babies take a big old breath and cry and they dry them so they don't get cold. And it's really important. So that's it. Honestly, that's what you need to do for most babies is like, hello, you're out. It's time to breathe and like take this
Welcome to the
over
world.
on your own. Welcome to the world. So get that going. Stimulate the baby. That's your initial stabilization. And then once you do that, if the baby's bradycardic, and bradycardic for a newborn is less than 100, not 60, not
important.
40, 100. So it's fast. Okay, it's fast. Or they don't have adequate respiratory effort. After you kind of stimulate them, then you need to do some sort of ventilation. And ventilation is so important. So BVM is the first thing you're going to grab. So be prepared. And again, it's teeny tiny little person.
Exactly. Little
so
tiny
it's that
mask.
little tiny mask. And if you really need to, you can go on to LMA or intubate if that's not effective. But honestly, it is really effective most of the time. Now, if despite bagging or even intubating, you can't get the heart rate up over 60, so that kid gets bradycardic. We know that it's usually hypoxia in a newborn that they get bradycardic. You need to do something. And you're going to have to give them more oxygen somewhere along the way, but you're going to have to start chest compressions.
Yeah.
Heart rate under 60 is just too low for a newborn. The compression ratio is 3-to-1 for compressions to ventilations. Make sure it's the adequate depth. 2 fingers, the 2 thumbs is preferred, not the little 2 fingers on the front, but wrap them around, sort of cuddle them in your hands and use your 2 fingers. And then if they still stay bradycardic, no matter that, even with that, then you might need IV epi, and then make sure that they're not hypovolemic. That's usually a cord problem. They don't have attention, and they're not in cardiogenic shock. So those are the things to kind of think about if they just still are just not doing well after you've delivered them. Now, if you've delivered them and they're not critically sick, so it's that, yoo-hoo, all 3 questions are answered great, it all looks good. What they recommend doing is delayed cord clamping. There's pretty great data on this to be out there as far as it benefiting the baby. And the delay is 30 to 60 seconds. So baby's out, you're hanging on. Good tone, full-term baby, crying like crazy. You hang on to that baby at the perineum, wait 30 to 60 seconds, and then go ahead and clamp the cord. What you get from that is remarkable. You get decreased sort of need to transfuse them later, decreased intraventricular hemorrhage, which is enormous. That's a huge thing. Decreased necrotizing enterocolitis, higher blood pressures and volumes for them. It's great for them. It doesn't decrease mortality or bad intraventricular hemorrhages, but it's actually overall incredibly beneficial. The only downside, if there's any, is their belly might be up a little and they might need a little more phototherapy, but that's easy stuff. Yeah. So the baby's out. You've done the whole get them sort of going and they're breathing on, they're doing okay. Keep them warm. It's, if you think about it, if I'm especially if I'm a low birth weight baby, I've got a lot of skin with no sub-Q fat of any kind. My skin is really thin. I have a large body surface area. They tend to lose heat pretty easily. So those babies, you gotta keep them warm. That's why the warmers are super important. And if they get less than 36.5, that's not much below normal.
Yeah.
They increase their mortality. So warming them is so important. So put them in the radiant warmer. Dry, make sure all the linens are dry. So if one is goopy, get rid of it and get a fresh, clean, dry one. Put that little cute little hat on that. Yeah. You lose a lot of heat out of your head, so put the little that hat on that. Get the room really hot. And if you've ever been in an L&D suite, it's bloody flipping hot in there because they want the baby to be warm. Thermal mattresses are great. Warm humidified gases are good. And there is even for the preterm babies, sometimes they saran wrap the kid and wrap them up in plastic.
In actual plastic.
True plastic wrap. Honest to God, it's a little creepy, but it
works. They have like these little plastic pouches that they
just slide the baby in there and kind of just cinch it, and there they are, all toasty in there, sort of like you can cook a turkey like that. So there you go. If there's any sign of airway obstruction as you deliver the baby, get the baby's mouth open. Often that's it. Or use a jaw thrust or a chin lift. That's it. Yeah. Only suction if you need to. That used to be the de rigueur, right? Every baby on the perineum, you'd suction out all the goobies in there. Well, it turns out you need those goobies. It actually populates your gut. It's actually remarkable. It's hugely important for your microbiome in your gut. So it doesn't really, and suctioning is a problem. You suction a newborn. Yeah. Remember, I want their heart rate over 100? Well, that's going to get their heart rate low because the vagal response is exaggerated. So
I think this is a big one, like compared to people, when those of us who learned our OB a long time ago, this is a change from what most of us learned.
Right, because you keep calling it the bulb syringe. Where's the bulb syringe? It's okay if it's lost.
Yes.
Because you don't really need it. You don't, and even if it's a mech baby. So you get a baby out and there's all that goopy mech in there, that kind of greenish, blackish stuff. Yeah. You do not routinely intubate and suction kids, even if they're depressed neonates. Okay, you don't routinely. You go ahead and try to stimulate them, get them to ventilate. You don't suction that stuff out of there in most cases. Now, if you do stimulation and airway, I've opened the airway, I've stimulated the baby, but they're still bradycardic. I'm going to bag them, and the rate I'm going to bag them is 40 to 60 breaths a minute. So that's a lot. Okay, that's really, really quick. That's once a second. Okay, and even mech babies, if they're depressed, you're going to do it even with a meconium baby. And you're going to put it's interesting actually. I didn't think about this, but this makes sense. You're going to put their oxygen saturation probe on the right upper extremity. That's before the duct. Right? So what you're going to get is actually true oxygenation, not something that might be, if the duct just hasn't closed yet, things might be going on the left side, looking a little mixed. On the right side, it should be what's coming out. So that you want the right upper extremity, pre-ductal. And you're going to start with a FiO2 of no more than 30%. And what you're going to do then is you're going to titrate to how long they've been alive, how long they've been out. And it's interesting, a newborn saturation is 60%.
Yeah.
And a baby that's newborn and only 3 minutes old is 70%. It takes up to 10 minutes to get you into the 90s. So if you have a baby whose sats are, 70% at 2 minutes, you're good to go.
Exactly. It's okay.
You are good to go. That is fine. And this little table on this slide is actually in the article as well, is really worth kind of just the concept. Remember, they are hypoxic to start, and it takes up to 10 minutes to get normal.
The curve takes a little while. We actually have this laminated and pasted on our warmer just to remind everybody.
Oh, that's really smart.
Because
that's a great idea.
It's your reaction. 3 minutes is a long time for those of us who don't deal with neonates very, very often.
Right.
And so you can imagine that if you saw that sat, you'd be like, oh God, I got to intubate this kid. And the answer is you don't. You just need to wait and just give it a little bit more time to get everything sort of settled.
Right.
So,
really good teaching point. And actually, that's a very testable kind of concept in this particular article. Now what you're doing, so I'm resuscitating, I've got the bagging going on, I'm watching the SAT, which is now preductal, it's on the right arm, I'm like good to go. I'm gonna continuously watch things like what the heart rate is, whether they're breathing and how much they're trying to breathe. I'm gonna see if my positive pressure ventilation is working. We'll talk about how to do that in a sec. And one of the things I really my goal here to know I'm oxygenating this baby appropriately is heart rate. We know that heart rate is very sensitive to how well you're ventilating. So heart rate is crucial. If it doesn't come up, you're going to consider intubating. Again, that's really, really important. Now, if you have to do chest compressions, you got to put an airway down. So if you're getting to the point where you need to do, chest compressions in a baby, put an airway down. So intubate them, advanced airway placement, or LMA, I guess, is an alternative as well. And while doing chest compressions, the FiO2 should go up to 100%. However, as soon as the heart rate comes up and you can take your hands off the chest, drop it down. Oxygen toxicity is really real, especially in babies, especially in newborns. So once they're breathing, et cetera, you're good to go. Now, if the kid remains blue, despite their heart rate being up and they're breathing, or if they still look like they're working hard to breathe, despite a good heart rate and a respiratory effort, then what you probably need is continuous positive airway pressure. There's something wrong, either probably congenitally with that kid, and you're gonna need to do something like bag them with increased pressure. So you're gonna have to have positive airway pressure added into that. Now, monitoring the heart rate tells you, again, how good your ventilation is. And in the first couple of minutes of life, trying to take a radial pulse is hilarious in a newborn. It just doesn't work. So what you really want to do is take your fingers and put them at the base of the umbilicus. It's a really, really, really strong pulse. You can feel it there. Or if it's not super noisy, which it never isn't noisy in the ER, you can listen. But better off just keep your fingers on the pulse at the base of that umbilicus, put your fingers there. And then once you get them on the monitor, go ahead and you can follow the heart rate monitor once you have them on a monitor, or you can follow pulse ox. So it turns out pulse ox, if you see that sort of up, down, sort of rhythm, the strip of a pulse ox, that's good to follow as well. Now, again, we talked about in circulation, if their heart rate's less than 60 and I'm adequately ventilating, I need to support their cardiac output. I just have to. So I'm going to do CPR, two-thumb technique. You don't get as tired. You may need to do this for a while. And your ratio of breaths to compressions is basically 3 to 1. Okay, so that's your goal. Good luck, though. You're going so fast, it's really hard. I think you just basically push, and then breathe quickly. And that's, yes. Medications and fluids, if you get to the point where you're like, okay, now I need to do something more than just bag them, more than just, I need to actually get some drugs maybe in there or some fluids in there because they just don't have a high heart rate. They're just not perfusing. Basically, again, ventilation is first, but if they're still bradycardic, I need to give something to help that poor heart. So bradycardic, despite adequate ventilation and compressions, you go to epi. Sometimes volume expansion. If you think they're really hypovolemic, they bled, there was a lot of cord blood loss, and maybe they lost a lot of their blood that way, you're gonna use epi. It's 0.01 to 0.03 if you have a 1 to 10,000. If you do it parenterally. If you don't have IV access, though, you can put it down the tube. So if you endotracheal tube, you can put 0.05 to 0.1 milligrams per kilogram down the endotracheal tube. Now, once you've done that and then you get an IV started, you immediately give an IV dose because we know for sure it gets there, IV.
Yeah.
So you immediately do that. If you think there was blood loss during the delivery, usually it's cord for the baby, or there's signs of hypovolemic shock or whatever, you can use crystalloid or blood. And either one, it's a 10 cc per kilo or 10 ml per kilo dose. And if it's a preemie, if it happens to be a non-term baby, you're going to give that slowly. Giving it too fast increases the risk of bleeding into their head. So you want to give it slowly. And what do you do for access? So if you have the god or goddess of IV starts in newborns as a person working in your ER, have them go ahead and try a peripheral. But I got to tell you, when it's this critical, you're going to do something like an umbilical venous catheter, which honestly are so easy.
Yeah,
2
they are
arteries,
really
1
easy.
vein, you feed it into the mouth,
Yes.
right? It's that, ooh, Mr.
Yes.
Bill mouth.
Yeah.
You put it into that. Those of you who don't know who Mr. Bill is, just Google it.
Yeah.
It was awesome. So put it in the mouth for
Put it
that.
in the mouth.
Or use an IO line. You can basically do that in newborns as well. Just be careful because they're teeny, so don't go all the way through in those. So either one of those is fine. And then, so now you have the baby back, and I have a pulse, and I've intubated or not, but I have now a pulse and a pressure in this kid, and I now have this resuscitated newborn. What are sort of the things I need to do now? I've resuscitated. What's the ongoing things to do? So thermoregulation is important both directions. So make sure they don't get cold. That increases all kinds of trouble like bleeds in their head, metabolic trouble, respiratory trouble, even increasing mortality. And don't let them get hot. Again, they also have increased mortality, but they may get meconium aspiration syndrome. They may need prolonged assisted ventilation. They may get ARDS. So they may seize. So your target temperature is just right.
Yes. Not too hot.
Not too hot, not too
cold.
cold.
Just
36
right.
and a half to 37 and a half.
Yeah.
So that's crucially important. So if they're on the warmer and they're actually doing okay, nice and bundled, they may be able to come off the warmer. So keep track. And you kind of lose track sometimes in the ER. You're all excited because you resuscitated the baby, but keep track of this. It's important. Now, there is a concept in these newborns of therapeutic hypothermia. Honestly, it is not done in the ER. It's only done sort of upstairs in the neonatal ICU, and I'm throwing it out as a concept. Please do not waste brain space. This is nothing we're going to be doing here in the ER. Yeah. But you should monitor the glucose. So several hours after birth, the baby's glucose levels can plummet, especially babies that have had a mom with sort of prenatal or perinatal diabetes. So this is the group. Preemies have it, big or little babies, so too big or too small, little babies have it. Growth restricted babies, so they basically had a reason to be smaller. Again, gestational diabetes is a big one, or there may be septic. So watch it. If that kid, if it's a big one or a little baby, or you know it's a preemie, watch that sugar. Really, really important to monitor. And they may get more lethargic, they may start to tremor, they may be irritable, they may get floppy. There's lots of things, they may seize. There's lots of things that can happen when a newborn gets hypoglycemic, and your job is to fix it. Now, you don't grab the D50.
Yeah.
Don't do that.
That's important.
Grab D10. It's D10W, it's 2 cc's per kilo, but make sure you know, now that you've resuscitated this baby, where is the D10 in your hospital? And you might want to have it on most of us have it. If you have the pediatric cart kind of stuff, it's there, but no, it's D10. And then start IV fluids with dextrose in them. You're going to need to have a little bit of infusion, usually D5W, at 4 to 6 milligrams per kilogram per minute, or cc's per kilogram per minute. cc's per kilogram per minute. Frequent assessment of glucose, so check it on a regular basis. And then there's some labs someone's going to say, and make sure the mom over there, we send some labs, almost all of which are related to infections. Hep B, HIV, syphilis, Group B strep culturing, chlamydia and gonorrhea testing, rubella screening. A lot of things that have to do with infections the baby may have picked up. You need to know mom's blood type and antibody testing, and with the sort of gestational diabetes screening. So there's some specifics in the article about what to do about those, but honestly, again, out of our realm of what we're going to do. If the baby's going to be around for a while, you don't have an L&D where you are, and you're going to have to transfer this baby, erythromycin eye ointment is recommended, and you don't have to do it right away, but it's recommended in the first hour of life. So they do, and this is actually a national recommendation from the CDC. It's interesting. I was looking this up on the web. If you Google this, there are a whole lot of I don't want this for my baby kind of websites out there, but just know for us as a practitioner, we practitioners, we're sort of obligated to do this. It's a CDC recommendation, AAP recommendation. So you're going to put ointment in the eye. There's a dosing here that you can look at, but just remember the concept. Probably better to do an exam of the eyeballs before you do it because they are goopy and irritated for about an hour. You can't see much in there. It's also recommended to give vitamin K, interestingly. So there's a thing called hemorrhagic disease of the newborn, not common, but it's basically a vitamin K deficiency state. And you fix this with a single dose of IM vitamin K. So you can use it in the deltoid, probably better because it's most muscle mass these little critters have, so it's probably the best place to put it. And this, again, is for this vitamin K deficient bleeding that they can have. Now, somewhere along the way, you should, somewhere in the back of your mind, also be thinking about doing an APGAR. APGAR is important for prognosticating down the line and for what to expect from developmental issues as well if the APGARs stay really low. So if you have the wherewithal, and again, it's probably a nice thing to have on your little, where you have taped what should your FiO2 be at certain states, should be how to do your APGAR. Don't try to memorize it. That's what apps are for. That's what your phone is for.
Yeah. You're not expected to know all of those different boxes.
This, the 5 components and how to score it, but it's a score of 0 to 10. And there's certain scores that sort of how often you should repeat it. If they're over 7, they're screaming bloody murder. They're nice and pink. They're, their tone is wonderful.
Fine.
You're done. That's fine. You're done. So, big article, lots of information, but actually very easy to understand and very straightforward. So just be prepared for delivering a baby in your ER, and once the baby's out, it's not just mom now you have the baby. How to resuscitate the baby, be prepared with all the equipment that you need for this, and at the time of delivery, remember to delay clamping the cord, keep the baby warm, open the airway if you need to, suction only if you have to. Don't basically, do routine suctioning in babies, even if they have meconium.
Yeah, so less interventions.
Just let the. I mean, nature's been
bit.
doing this a long time.
Right.
It's been going okay for quite some time. If you do a saturation monitor, you need it. Put it on the right side. If they're bradycardic, it's usually hypoxic, so bag them if you need to, and only use the oxygen you need to get to the saturation that's appropriate for their age, which we talked about earlier, for their minutes of age at that point in time. If they're still bradycardic despite oxygen, go ahead and do positive pressure ventilation. And if they're still bradycardic, then you need to intubate or use an LMA. If even then they're bradycardic, you're going to have to do basically chest compressions with the 2 thumbs. Your rate should be 120 a minute, which is kind of nice. That kind of is across the board for everybody.
Yep.
And the ratio of breaths is 1 breath per 3 compressions. If they're still sick, you're going to need to use epinephrine. The dose is, as mentioned before, or maybe fluids if they look like they've had a problem with blood loss. And then you're going to once you're done, you're going to target the temperature and get them appropriate. You're going to watch that baby's glucose. You're going to make sure mom gets some lab sent. You're going to stick that erythromycin in their eye, give them vitamin K, and do an APGAR. So you are going to be all over this.
Yeah.
It's actually a great article. It's very, very simple, very straightforward. Kind of a lot of things to talk about right now, but it's actually it's stuff you do all the time. It's just a little person.
And there were only 2 actual medications that we mentioned in the resuscitation, which really boils it down. There's epi and there's D10. There's really only 2 things. And then when they're born, there's the erythromycin and the vitamin K.
Yeah,
so there's
exactly.
really 2 and 2. It's pretty
and
straightforward.
it's your brain. It's stuff that you know how to do. As far as resuscitation, you've done it all. You just know the numbers are a little different, and it's resuscitation otherwise.
That's right.
There we go. You can deliver it. Have at it.